Welcome to Emergency Appraisal on Emergency Medicine. Myself, Dr. Ranjith, working as a consultant emergency medicine at Yashoda Hospitals, Hyderabad. This platform is creating an amazing opportunity to learn and share educational points and updates in the field of emergency medicine and meet some amazing people from across the globe online. This is organized by Yashoda Group of Hospitals in association with SEMI and accreditation of National Board Accredited Institutes. This is chaired by Dr. Srinath, who is a HOD Group Head Emergency Department, Yashoda Hospitals, Hitec City, Hyderabad. Dr. Naveen, HOD Senior Consultant, Yashoda Hospitals, Hitec City, is the Organizing Secretary. Dr. Suresh, Dr. Ranjith, and Dr. Kiran Varma are part of the organizing team, who are HODs of the group of Yashoda Hospitals emergency departments at various institutes. This week, our topic of interest is eclampsia. This is a component of a group of hypertensive disorders in the pregnancy, which includes chronic hypertension, gestational hypertension, preeclampsia, and eclampsia. The most common neurological complication of pregnancy is seizures. Eclampsia is a major cause of gestational morbidity and mortality due to risk of hypoxic ischemic brain injury and seizure-related intracranial hemorrhage. So as emergency physicians, we play a key role in recognizing and acutely managing patients with eclampsia and the ED. Today, we have our speaker, Dr. G. Priya, who is here to speak on eclampsia. Dr. G. Priya, she is working as an associated professor in emergency department from at the CMC Vellore. She has completed her MD anesthesiology and critical care from JIPMER, and she's a graduate and she holds MRCM degree as well. She's an instructor in AHA, BLS, and ACLS training, and also in early management of trauma course. She's working as a faculty for emergency ultrasound workshop as well. She's a provider in PALS. She's an assessor in QA. She's involved in the teaching of the undergraduates, postgraduates, paramedics, and the nurses in the emergency department. She was awarded the best outgoing student in her undergraduate, and she is a receiver of Dr. Shinoy Gold Medal during her post-graduation. Her fields of interest include simulation-based teaching in emergency department, acute pain management through nerve blocks, emergency ultrasonography, and quality improvement in emergency department. I welcome Dr. Priya to give an expert talk on the said topic. Welcome, Dr. Priya.
Thank you, Dr. Ranjith. Thank you for the gracious introduction for me. Good evening, all. Today, we are going to see about one of the important topics in obstetric emergencies. Though obstetric emergency we receive once in a while, these are the patients who are really salvageable if you take steps at the proper time. The identification and management of each patient is very, very important. So today we are going to see about eclampsia, which is one of the obstetrical emergencies. Shall we go ahead? Am I audible to all?
Yeah, audible. You can go ahead.
Next slide, please. Today, I'll be taking you through the objectives, mainly the introduction, what is eclampsia, what is the epidemiology, that is the prevalence of eclampsia in our population as well as the Western population, and what are the different types of presentations of them in our ED, and how to manage the same, and summarize the final findings. Next slide. Okay, coming to what is eclampsia. Eclampsia is defined as a new onset of grand mal seizure. That is nothing but the generalized tonic-clonic seizures or an unexplained coma during pregnancy or postpartum. Postpartum in the sense it is 42 days post-delivery in a patient with signs and symptoms of preeclampsia. It typically occurs in patients more than 20 weeks of gestation. It is usually considered as a complication of severe preeclampsia. I'll tell about what is preeclampsia and then when to diagnose this eclampsia. So it is nothing but again, I'm repeating once again, the hallmark finding in eclampsia is a generalized tonic-clonic seizures, which is lasting up to 60 to 90 seconds in duration. Usually these kind of patients will have a post-ictal state after the seizure activity. Okay, these patients can also have an RR like headaches, visual changes, blurring of vision or flashes of light, or an abdominal pain and increased blood pressure before presenting to the ED or the presenting with seizure activity. Next slide. So according to the UK eclampsia trial, the seizure eclampsia has been defined in little variation compared to what we generally will see. That is the seizures occurring in pregnancy or within 10 days. They are not gone up to the 6 weeks of puerperium. They have given only the 10 days of delivery with at least 2 of the listed things. One is the hypertension with the diastolic blood pressure of more than or equal to 90 millimeters of mercury, or a diastolic blood pressure increment of 25 millimeter above the booking value, plus proteinuria 1 plus or at least 300 milligrams per 24 hours, and a thrombocytopenia of less than 1 lakh per cubic millimeters, and the raised aspartate transaminase levels of more than 42 international units per liter. Next slide. So, as I already mentioned, any seizure that is happening in the pregnancy period or a postpartum within 42 days, we consider that as eclampsia, and it is a generalized tonic-clonic seizure, and usually the patient will have a post-ictal state as well as a preceding ARA. So be clear, it usually happens as a complication of preeclampsia, that is severe preeclampsia. I am putting the word usually, so we'll come to that later. Okay, now we'll see the different presentation of hypertension in pregnancy. It ranges from just a gestational hypertension or a chronic to a chronic hypertension. The in-between spectrum is the eclampsia and the preeclampsia. What is gestational hypertension? It is nothing but during pregnancy, if the patient is having a blood pressure of more than 140/90 millimeter of mercury, more than 20 weeks of gestation. If you diagnose that, we'll call it as a gestational hypertension. If it is less than 20 weeks, already the patient is a known hypertensive and having the blood pressure continue, we'll call it as a chronic hypertension. But where's this concept of preeclampsia comes? When the patient is having a gestational hypertension plus proteinuria, it can be a mild or it may be a severe. So it should be the proteinuria of measurable quantity of 300 milligram per cubic millimeter or deciliter should be there. And eclampsia occurs usually in a patient who does a severe preeclampsia, that is the seizure activity during the pregnancy. Next slide. So let us come see this patient. This patient explained the scenario of preeclampsia to you. He's a 22 years old, primary gravida, was examined and she's 32 weeks of gestation, and she has presented to emergency with a mild ongoing with epigastric discomfort as well as the headache, which does not relieve by taking paracetamol. And she also had a flashes of light and a visual spots. She gained about 10 pounds within the previous 2 weeks, nearly 3 to 4 kgs. And her blood pressure during presentation was 165/115 millimeters of mercury. Her fingers are swollen and she also had pedal edema. Her fundalitis 29 centimeters, and the urine dipstick is showing 4 plus protein. What are the important points that has been marked? Why it has been highlighted is this tells you the risk factors for developing a preeclampsia. One is the primary gravida, that is a high risk patient. Second is the 32 weeks of gestation, keep that in mind. And the patient is presenting with many symptoms. That is, one is a mid-epigastric discomfort, headache, flashes of light, seeing visual spots, and sudden increase in weight, as well as pedal edema with a blood pressure of more than 160/110. These all constitute the patient is having a severe preeclampsia. And the urine dipstick also proven it, she is having 4 plus protein. Why this? I'm stressing the 32 weeks of pregnancy. You always see a fetal complication associated with the preeclampsia is the IUGR. For a normal 32 weeks of gestation, the patient should have a abdominal fetal height of about 32 centimeters. But in this patient, the patient is having 29 centimeter, as well as the patient is having a little fetal distress of about 145. So this scenario tells the patient is having a severe preeclampsia. Anytime this patient can go into eclampsia through a seizure. So we need to put the patient resuscitation area priority 1 and resuscitate as early as possible. That's what we are going to see in the following slides. Next slide. So coming to the epidemiology, that is the prevalence of preeclampsia. About 10% of all pregnancies are complicated with hypertension. In that, half of that is mainly the preeclampsia, eclampsia, other half maybe the chronic hypertension or gestational hypertension. The preeclampsia constitute about 4.5 to 11.2% of pregnancies in industrialized country. It is mainly in the industrialized country, whereas compared to our developing country, it should be always on the higher side. I don't have a proper data for this. So what is the pathophysiology? Why it is happening? We always know during the second trimester, there will be a drop in blood pressure. That is after 20 weeks. But in these patients, that drop will not happen. What is the reason? It is mainly because of the abnormal placental development. Normally, what happens in normal pregnancy is that is a trophoblastic invasion of the trophoblast into the myometrium. Thereby, the arteries, spiral arteries, the resistance in these arteries are all will come down. Whereas that trophoblastic invasion will not happen in case of the preeclampsia patient or the gestational hypertension patient, which leads to increase in vascular resistance and leading into placental vascular bed ischemia. There is another theory also. This is a major theory that is considered for development of preeclampsia: absence of trophoblastic invasion during the second trimester of pregnancy. Another theory is the imbalance between the thromboxane and the prostacyclins that leads to that is a vasoconstrictor and the vasodilator imbalance that leads to platelet aggregation, thrombin activated, fibrin deposition, leading to small microthrombi formation in the systemic circulation that leads into increase in blood pressure. This leads to the other pathophysiology that is happening is because the protein loss, increased capillary permeability, and hypoalbuminemia is seen in this patient, and there is because of the increased permeability to maintain the blood pressure, they will go for the profound vasospasm and thrombosis, which leads to dysfunction in all the organ system. So this is the major pathophysiology behind the formation of the development of the preeclampsia in pregnancy. Next slide. So these kind of patients, what are the signs and symptoms they present to us? So I just put up the symptoms for the eclampsia. That is probably the severe preeclampsia patients who go into the, I'm just always using the word severe preeclampsia. Then what is meant by mild preeclampsia? So if you take preeclampsia, we divide into two types. One is a mild preeclampsia, another one is a severe preeclampsia. In the mild, the blood pressure will be more than 140/90 millimeter of mercury, and proteinuria is less than 300 milligram per deciliter. Then we consider the patient is having a mild preeclampsia. They will not have any signs of symptoms suggestive of what I'm going to discuss now. In severe preeclampsia, the blood pressure will be more than 160/110 millimeter of mercury, and they will have tachycardia, tachypnea, crepitation, hyperreflexia, clonus, papilledema, oliguria, that is end organ dysfunctions can be there associated. And most commonly, the patient present with mid-epigastric pain and generalized edema and small for gestation. The fundal height will be small for the gestation lane, and they will be very apprehended, and marked proteinuria of at least 3+ proteinuria will be present in these kind of patients. So this constitutes a scenario of severe preeclampsia who are all high risk for developing seizures at any point of time. Okay. This slide tells you who are all the risk factors. Already we discussed about one risk factor in the case presentation itself, that is the primary ganglia. Apart from that, we have other risk factors, namely the obesity and diabetes coexisting disorders, and increase extremes of maternal age. It may be a younger age, very 18 years she is getting pregnant, or it may be more than 40 years. Chronic liver renal disease, molar pregnancy, twin pregnancy, and previous history of preeclampsia in the previous pregnancy, RH negative, metabolic X syndrome because they are obese, or APLA syndrome. All those things are risk factors for developing eclampsia. Next slide. So to diagnose an eclampsia in emergency, so the eclampsia should manifest for one or more seizures, which should last for at least 60 to 75 seconds, with the blood pressure of more than 140/90, the proteinuria of more than or equal to 2+, with or without the coexisting systemic abnormalities of the kidneys, liver, or brain. So, but Though it is explained, the definition, everything tells the patient should have an hypertension, should have a proteinuria. There are 38% of patients who presented the seizures in pregnancy who are branded as eclampsia with the absence of hypertension with proteinuria. But in US, about 16% of such patients were also being reported. So with or without hypertension, any patient presenting to emergency in the pregnant period with a seizure, we always consider eclampsia as a first differential diagnosis. What are the differential diagnoses should be considered in these kind of patients? One is infection. It can be a cerebral malaria, or it can be any bacterial, viral, or any kind of meningitis or encephalitis, or it can be a stroke, or it can be a hemorrhagic or ischemic stroke, subarachnoid hemorrhages, cerebellar hemorrhages, or intracerebral hemorrhages, or it can be a metabolic causes like hypoglycemia, or it may be any hyponatremia, or it can be a brain space occupying lesion in pregnancy. So this is all will come after you load an eclampsia for the patient. Okay. Coming to the laboratory test, what we have to send from emergency department, what's the importance of each test? So we have to send a full blood count for the patient, mainly to load the infection and especially the platelets, because eclampsia usually they are associated with low platelet count. And liver function test, derange other liver function, pre-eclampsia, as I already did in blood data, thrombocytopenia, liver functions can be deranged, as well as the renal functions can be deranged. So you have to do a aspartate transaminase levels, albumin, as well as LDH to look for any LDH, any lysis, hemolysis is happening, which is a part of the HELP syndrome, which is the another complication for the pre-eclampsia, and fibrinogen level, because as these patients are severe pre-eclampsia, they can have different complications, which will come to the later. So they can have HELP, they can have DIC, they can go into liver failure, they can go to renal failure, they can have severe prosentemia, they can have other brain issues like cerebral edema. So CT is also involved. They can go into lung failure like pulmonary edema. So we need to take a X-ray in the ECG, X-ray as well as the ECG. Coming to the next slide, please. So what are the outcomes? What are the mortality that is associated with these kind of patients? Why the patient has to die? So it's mainly because of the maternal complication, mainly because of these patients, because the high PP, they can go into abruptio placenta, that they start bleeding. The really separation of the placenta can happen in the ED itself. So they start bleeding PV and they can collapse because of it. Or because of the hepatic rupture can happen. Or the patient can throw a seizure and because of cerebral edema and they can arrest. So these are major morbidity and mortality in a patient with severe preeclampsia. The mortality in the neonates is mainly because of they can go into acute respiratory distress syndrome, chronic lung diseases, intraventricular hemorrhages, cerebral palsy, sepsis, as well as necrotic enterocolitis. So next slide. So how we are going to manage the patient who will come to emergency with a seizure or with severe preeclampsia? So let us have the management. We will divide into mainly three different types. We are going to concentrate. First is the prevention and treatment of seizures. Second is the blood pressure control. Third is the expediting the delivery of the child. These are the major things that we have to concentrate on. Okay, whatever in an ED, whenever patient comes to us, the first thing always starts from ABC. First, look at the airway. If needed, you go ahead and clear the airway, breathing, circulation. Then go ahead with the anti-epileptic drugs and control of seizures, control of blood pressure, and finally the expedite your delivery. Let us come to the airway. What are the things you have? What is the problem in managing the airway in these kind of patients? These are the important things we have as an ED physician we have to keep in your mind. These patients actually had a seizure. So they have a lot of vomiters or secretion. There are high chances of aspiration in this patient. And they may be in the post-ictal state that they can be unconscious and then tongue fall back, they can be there and they may lose the airway because of that reason. Or because of the pre-eclampsia itself, there is generalized edema, there can be an airway edema also, which can complicate the condition of the patient. So these are the different reasons the airway can get obstructed in these kind of patients. If you think something, the airway is not compromised, we need to secure the airway in this patient, what we have to do. Let us come to the intubation. How are you going to intubate? If you want to secure the airway, the patient is not able to maintain the airway, so we are going to intubate the patient. What are the concerns that has to kept in the mind? As I already previously mentioned, the patient is already has seizure or is a full stomach or is a pregnant patient, that itself increases the chances of aspiration. So we have to go ahead with a rapid sequence induction in this patient or a modified rapid sequence induction. Either we have to decide about the assessment of the airway, whether I'm going ahead with the RSI or a modified RSI, depending upon the ease or difficulty of your assessment of the airway. What are the concerns when we decide about the RSI? As we all know, RSI, we are going to give the drugs and followed by intubation. We won't have much time. We won't be ventilating. If we ventilate, the chance of aspiration is going to increase. So we will not ventilate so much. So there is high chances of desaturation and landing up in a situation called a CBCA. So we need to be very clear what we are the things. So preparation is very, very important. What are the things we need to prepare in these patients? One is as already mentioned, this patient is a pre-eclampsia patient where the patient is going to have a lot of edema everywhere. That edema is not only present in the entire body, it's also going to be there in the airway edema. So we have to choose a smaller size endotracheal tube. Normally, if you choose a 7-size endotracheal tube for a normal pregnant female patient, you have to go ahead with a 6-size endotracheal tube. And we also have to get ready with the facing a difficult airway in this patient. So because of the small glottis and then huge breast, as well as the high Malakpet score and increased risk of aspiration. So never ever go and intubate this patient without the senior help is present. So call for help is very, very needed for intubating these kind of patients. Okay. Previous slides, I wanted to tell some more points. So when you're going to intubating these patients, choose a smaller size endotracheal tube, size of about 6 or 6.5, and then go ahead and do a rapid sequence induction. And if you're suspecting the patient is having a huge breast, which is going to impede your placing of laryngoscope, use a short handle laryngoscope for intubation. And fourth thing, most important, is these patients are already having a high BP and they are prone to show a exaggerated intubation response. So which can lead into acute pulmonary edema or intracranial hemorrhage while intubation. So blood pressure control during intubation is also very, very important. So you have to choose a drug, either propofol or thiopentone, to intubate the patient rather than choosing ketamine for intubation. Next slide. So we already discussed about the issues with the airway. If the patient requires intubation, what are the things that has to be done, how to prepare the airway, difficult airway card, everything we have been discussed. Now going ahead with the breathing, what are the problems we have? We all know that during pregnancy, the functional residual capacity decreases. In this kind of patient, it is further decreases because of the pre-existing pulmonary edema. So we have to pre-oxygenate this patient very, very adequately. So because of poor oxygenation, anytime the patient can go into desaturation and can go for a hypoxic currents. So make sure whenever possibility is there, give oxygen irrespective of the saturation of the patient. If you're planning to not intubate the patient is maintain the airway post seizure, try to nurse the patient in the left lateral decubitus position. As we always know, that improves the circulation in the patient, as well as it also increases the oxygenation of the patient, as well as it will prevent aspiration, secretions to come out through the mouth and then prevent aspiration. Coming to the circulation, so the patient can present with hypertension or hypotension. We all know the patient will present with hypertension because it's a complication of preeclampsia. Why there should be hypotension? If you make the patient lie down supine, there is a supine hypotension syndrome which is there in the pregnancy, which will get exaggerated in case of the preeclampsia or the eclampsia patient. So better you have to keep a pillow below the right buttock to make sure the left uterus is displayed to the left side. And regarding the fluid resuscitation, you have to use a colloid for resuscitation rather than a crystalloid, because as I already mentioned, they lost a lot of proteins in their urine. So they're going to have hypoproteinemia that increases the vascular permeability of the patient, which is going to cause more of fluid going into the third space. So you have to use a drug which is, we have to give very little, the fluid it should stay in the compartment. So most likely should be a colloid, either the gel fusion or the tetrastarch can be used for resuscitation of this kind of patients. Then we are done with the airway, we are done with the breathing, we are done with the circulation. Then what we have to do? The important thing is the control of seizures. According to many trials that have been done, magnesium sulfate is the drug of choice for control of seizures in eclampsia. So magnesium should be given as a loading dose of 4 grams direct IV in 100 ml NS over 15 to 20 minutes. And it should be followed by the infusion of 2 grams per hour should be continued until I'll come to that. Okay, so what's the problem when you start magnesium? So magnesium sulfate is prone to cause respiratory paralysis. It also depresses the central nervous system and it itself can cause hypotension and cardiac arrest. So we should be very careful when you have started the patient on magnesium sulfate. Once you start the patient on a bolus dose of magnesium sulfate followed by infusion, we have to monitor few things to make sure we are not going to the toxic levels of magnesium sulfate. What are those things that needs to be monitored? One is the patellar reflex that has to be present when you're planning to continue the infusion. Every second only you have to measure see for the patellar reflex. Then the respiratory rate should be more than 12 per minute and the urine output should be at least 100 ml over the past 4 hours. If possible, you can see for the therapeutic blood levels of magnesium, which should lie between 4 to 7 milliequivalents per liter. If you feel the patellar reflex is absent, better to stop the magnesium sulfate. And if you feel the magnesium levels in the blood are more than 7 milliequivalents per liter, the patient has developed a respiratory depression and the respiratory rate is less than 10, you can go ahead and treat the magnesium sulfate poisoning toxicity by using calcium gluconate. How much we should use? Normally we'll use 10 ml of 10% IV calcium gluconate over 10 minutes should be given to the patient. So, okay, the patient is allergic to magnesium sulfate or the patient after giving magnesium sulfate also the seizures are not getting controlled. What are the drugs that can be used in pregnancy? One is a benzodiazepine, the patient airway to be secured and you can go ahead and start the patient of midazolam infusion or you can use barbiturates. There are few sets of patients where we should not use magnesium sulfate or the phenytoin in this patient. Those are patients who already are known cases of having muscular dystrophies, like myasthenia gravis. So these kind of patients, we won't be using magnesium or phenytoin. Those kind of patients, you have to go ahead with either levetiracetam or the valproic acid. So as management of seizures, the first drug, the first line of management is magnesium sulfate 4 grams followed by 2 grams of infusion, but make sure you have to monitor for the toxicity of magnesium. If not controlled, go ahead and use benzodiazepines or barbiturates. In patients who you can't use magnesium or contraindicated like neuromuscular disorder patient, use Levipil or a valproic acid. So whenever patient arrives, ABC has been stabilized and you treat the seizures, immediate and important thing has to be done is involve the obstetrician immediately. Because as I mentioned, the third step and most important step is the delivery of the child. In between time, we have to concentrate the second thing, that is your blood pressure management. Here, the goal of blood pressure management is keeping the systolic blood pressure less than 160 millimeter of mercury and the diastolic less than 110 millimeter of mercury. The commonly used antihypertensives during the pre-eclampsia or the eclampsia is labetalol, hydralazine, or nifedipine. These are the 3 drugs that has to be used to control the blood pressure. We'll come to that now. What are the drugs that needs to be given? We have to consider both antenatal steroids and we have to keep the patient nil by NPO. These are the other things that also has to be taken into consideration when you are treating a eclampsia patient. So how to control the blood pressure? As I already mentioned, the first line medications are labetalol, nifedipine, and hydralazine. Let us go to labetalol. Okay, labetalol, the initial dose of labetalol is 20 mg IV. So every 20 minutes, you have to assess the patient blood pressure. If the blood pressure is not coming down, you can double the dose of labetalol every 20 minutes until the blood pressure is controlled less than 160 by 110. If it's emergency, you can come down the duration to 10 minutes. So maximum dose of labetalol that can be given as a total is 300 milligrams. If the patient is conscious, only pre-eclampsia, we need to control only the blood pressure. She is not thrown a seizure yet. You can use nifedipine orally, not for a patient who has already had a seizure. So nifedipine can be used 10 mg nifedipine, and every 30 minutes you can reassess the patient and then you can give 20 mg. Second dose of 20 mg can be given after 30 minutes. The blood pressure for whatever it may be has to be less than 160 per 110 to prevent onset of seizures. The third drug that though you're not commonly using is the hydralazine. Hydralazine is the dose is 5 to 10 mg. It should be given over 2 minutes. The additional 10 mg can be given after 20 minutes. So, as I already mentioned, the goal of keeping blood pressure is 160/110 millimeter of mercury. So, this is the blood pressure control during pregnancy. So, we have dealt with the airway, breathing, circulation, anti-epileptic, as well as the blood pressure control. The finally is the delivery of the child. So, for delivery of the child, we have to consider few things. One is the treatment or the definitive treatment for any preeclampsia or eclampsia is deliver the child irrespective of the maternal gestational age. Okay, so whenever the patient present to us with more than 34 weeks of gestation and the patient is, you can go ahead and deliver the mother after deliver the fetus after stabilizing the mother. If the mother is presenting to us with less than 34 weeks of gestation, you can give steroids. Corticosteroids can be administered for the patient, and this delivery should not be delayed just for the administration of corticosteroids. So as I already mentioned, the definitive treatment of preeclampsia and eclampsia is delivery of the fetus. Then only the blood pressure will come down and the patient's seizure activity will stop. So how to manage the patient post-delivery? The blood pressure control and the seizure medication has to be continued post-delivery of about 48 hours. The magnesium sulfate, which was started as an infusion for control of seizures, has to be continued at least 24 hours post the last seizure or the post-delivery of the patient. The systolic blood pressure should be maintained with less than 150 millimeter of mercury. Anytime if the blood pressure is going above 160/110, you have to control the blood pressure as early as possible so that you can prevent the seizure in those patients. So what are the prevention? So as we already know, how to manage the eclampsia patient. If the patient comes with seizures, what are the things that has to be taken care of for managing this patient? But how to prevent happening of seizures in these kind of patients? So one is, as already mentioned, one is prophylactic magnesium sulfate. That is, whenever the patient is having a blood pressure of more than 160/110 millimeter of mercury, in the emergency itself, we can start the patient on prophylactic infusion of magnesium sulfate. That is 2 grams of magnesium sulfate bolus followed by 1 gram per hour. The off the dose of the therapeutic dose can be used as a prophylactic magnesium sulfate dosage. And second thing, as I already mentioned, blood pressure control, the same medication, labetalol, can be used. So the target blood pressure should be maintained is less than 160/110 millimeter of mercury. So when we'll start antihypertensive medication, whenever the patient is having according to American College of Obstetricians, so whenever the patient is having a blood pressure of more than 160/110 millimeter of mercury and 2 occasions about 4 hours apart, we are considered the patient as preeclampsia and you have to start the patient on antihypertensive medication. Next slide. Okay. So we have been controlling everything. We have been treating the patient, but main thing we should not forget about monitoring the patient. What are the things we have to, that has to happen hand in hand? We all know emergency, we have to do many things hand in hand. One among them, most important thing is the monitoring. Here, there are 2 things, 2 people are there. One is the mother as well as the feeder. So you have to monitor both of them. What are the things that has to be monitored for the mother? One is the IO chart, input-output chart of the mother should be managed. Second thing is the respiratory rate. As I told, the patient is going to be on magnesium sulfate. We can't give magnesium sulfate if the heart respiratory rate is less than 12 per minute. And you also have to maintain whether she's going into active labor or not. So CTG has to be connected to the measure, and we have to monitor the patient for uterine contractions. For the fetus, what are the things has to be monitored? One is the fetal Doppler to check for the fetal heart rate and tracing, and abruption in the mother, which is the most common complication of preeclampsia and eclampsia, has to be vigilantly looked for. Next slide. So as I already mentioned, we need to monitor the pregnant woman very, very carefully. If pregnant, you are planning for delivering the mother, you deliver as soon as the patient is stabilized and deliver regardless of the gestational age if the patient is throwing a seizure. And if the patient is having a temperature more than 38 degrees Celsius, get the culture and give of the antibiotic. And depending upon the favorability of the cervix, either go for a vaginal delivery or a planned section for the patient. Next slide. Coming to the antepartum during delivery, what are the things? Important thing is the pain relief. because sometimes we have to deliver the patient in the emergency itself. So we are all equipped with labor ward next to the emergency. So we have to deliver the patient. For that, we have to provide an adequate pain relief, because this, if you allow the patient to strain, it will increase the pressures and the patient can go into any complication like acute pulmonary edema or the ICD. So make sure pain relief is provided properly, either through systemic opioids or epidural analgesia. In the absence of fetal malpresentation and a favorable service, as I previously told, you can induce the pregnancy delivery also by using oxytocin. And make sure you're not going to give methergine in this patient. Methyl ergometrin is contraindicated in a pre-eclampsia patient. Cesarean delivery, if the cervix is not familiar, you go ahead and do a emergency delivery. Next slide. Okay. For non-emergency cesarean delivery, as I previously mentioned, you can go for epidural and as a epidural and spinal, combined spinal epidural. But the problem here is the platelet count. These patients can have a low platelet count, so regional may be very, very unsuitable for them. Avoid giving a spinal or any kind of epidural analgesia for these kind of patients. But go ahead with general anesthesia. But general anesthesia is not without difficulty. As I already mentioned, the airway is going to be a difficult problem. The patient can anytime go into intubation response and then lead to acute pulmonary edema or a IC bleed. So that has to be taken care of when you're planning for anesthesia or intubating the patient in emergency. Next slide. Okay, so we have just seen how to manage the patient in emergency, but we also have to know what are the complications that can happen because of eclampsia and how to manage it. So ABCD, in D, anti-epileptics has to be done, as well as control of blood pressure, and E is for expedient delivery of the fetus. This A, B, C, D, E should be followed very clearly when you're managing a eclampsia patient. So we are done with that. So what are the complications we have to expect? As I already mentioned, airway compromise is the most common complication in post-seizure patient, so which may require ventilation. We have already discussed enough and more how to manage the airway in these kind of patient. Second most complication is the HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. So make sure that if the patient is having these kind of problems, you have to be very, very careful. They can anytime go into DIC or they can bleed and die. So mortality is very high in these patients unless you identify properly. Or the patient can have a stroke mainly because of intracerebral hemorrhage or a cerebral edema because of the increased fluid accumulation. One other complication is the press. We'll just tell you what is press. Another thing, as I told, increased blood pressure can go into a flash pulmonary edema or ARDS because of infection, coexisting infection, renal or liver failure, and ultimately anytime the patient can go into cardiac arrest. So be prepared for managing a cardiac arrest in a patient who is having a eclampsia. And never ever allow the patient move from the bed, because small movements of the patient can also lead to increase in blood pressure and lead into uncovered complications. Okay, I have a small note about other few complications. One is the press, which is otherwise called as the posterior reversible encephalopathy syndrome or the posterior reversible leukoencephalopathy syndrome. Both are synonymous, and it's a neurological condition where the patient can present with severe headache, seizures, change in mental status, cortical blindness, and other visual disturbances. Usually this is the prognosis of press is very, very good. If is usually identified by doing a CT where we can see the bilateral occipital infarcts. That is a typical finding for a press syndrome. If you intubate and ventilate this patient and control the blood pressure and the seizures in this patient for the next few days or weeks, the patient outcome is very good and the neurological outcome is also very good. But one thing we always need to monitor in this patient is the intracerebral pressures, because cerebral edema is the most common complication of press, which can lead into fatal complications like brain death. Second complication is the most common complication is the HELP syndrome, which is one of the fatal complications of eclampsia. As I already discussed, hemolysis, which is usually identified by a blood picture of increased serum bilirubin of more than 1.2 milligram per deciliter, or cystocytes present in the peripheral sphere, which is suggestive of hemolysis, and low serum haptoglobin and increased LDH, all suggesting of hemolysis and severe anemia unrelated to the blood loss. That is very important. We can't transfuse blood in this patient. If you transfuse blood also, it is going to get lysed. So very, very careful. Usually HELLP syndrome is managed by use of steroids and increased liver enzymes and platelet count less than 1 lakh. These three things together constitute a HELLP syndrome. Usually the management of HELLP syndrome is by corticosteroids. Next slide. So we have come to the end of this, but it is the most important part of it, which is the patient education, which is patient diagnosed with hypertension or pre-eclampsia during their family members as well as the patient needs to be get educated regarding their signs and symptoms suggestive of pre-eclampsia. When they need to report to the hospital, what are the importance of taking the medication regularly? These things you have to put into, you always, whenever the patient comes, a priority 3 patients, a priority 2 patient, make sure that you explain clearly what is the importance of hypertension, what are the complications they can develop, and what they have to look for, and what is the importance of sticking on to the medications. Okay, next slide. So these are a few food items food activity, general activity that needs to be emphasized to the patient. No more added salt. Drink plenty of water, avoid fatty foods, get enough rest, exercise regularly, at least 30 minutes of walk is enough for them, and usually refrain from any alcohol or caffeinated drinks, and take medications, hypertensive medication regularly as prescribed by the doctors. These are the few things that has to be stressed whenever you are discharging the patient with priority 2 or priority 3. To summarize the management part of eclampsia, so all the hypertension emergencies. One is pre-eclampsia, as I already mentioned you. It's between BP more than 140/90, but less than 160/110. It is, if the patient present to us with less than 38 weeks of gestation, we have to go hospitalize the patient, give glucocorticoids, and try to deliver the child. More than 38 weeks, go ahead and deliver the child immediately, depending upon the patient. And start magnesium sulfate seizure prophylaxis, both intrapartum as well as the postpartum. This is for mild pre-eclampsia. Pre-eclampsia, whatever may be the duration, you have to go ahead and deliver the child. Less than 32 weeks, as I already mentioned you, hospitalize, give glucocorticoids, and deliver the child. 26 to 32 weeks, again, deliver the child, magnesium sulfate, and control the blood pressure. And then, if it is, go ahead and give your glucocorticoids, but make sure that fetal lung maturity is not only sometimes fetal lung maturity, we should not delay the delivery just because the patient is having a poor fetal lung maturity. So as eclampsia, we have 3 things that has been put. First and foremost, though it is not under us, mainly by the obstetrician, the delivery of the child. If it is more than 36 weeks, deliver the child, control the seizures and antihypertensives. More than 20 weeks, stabilize and try to deliver the child depending upon the condition of the cervix. And then same magnesium sulfate for seizure medication and antihypertensive medications. So at the last slide, the take-home message from this lecture is eclampsia is one of the obstetrical emergencies. Though we may not receive the patient as properly seizing to emergency, but control is very, very important. If the patient present to us with in the severe pre-eclampsia state, you have to control the development of the eclampsia. Second thing, whenever the patient had a seizure, magnesium sulfate is the drug of choice, and control the blood pressure using labetalol, and prevent the further episodes of eclampsia seizures by continuing the infusion of magnesium sulfate. Not but the least, always educate your patient properly, what complications they can develop, what they have to look for, how their lifestyle should be, and before discharging the patient. Thank you. Any questions? Any questions?
Any questions are welcome. It was an amazing presentation, Dr. Priya.
Thank you, Dr. Ranjith.
Any questions?
If
please?
anyone has any questions, the chat box is open, and also QA section can be done. So we have one question.
role of other anti-epileptics other than medications. As I already mentioned, Maxelf is the first line of drug for any seizure patient that is presenting during emergency. If the seizure is not controlled with Maxelf, you can go ahead and control the airway, intubate the patient, start the patient on midazolam infusion or barbiturate, phenobarbital can be given. And if the patient, you can also use Levipil and phenytoin, but Maxelf, if it is contraindicated for Maxelf only, you have to go with other medication. As I already mentioned, the first line and most important drugs, according to many trials, that is proven to be magnesium sulfate.
There's one more question in the QA, ma'am.
24 weeks with just eclampsia, do we give Maxelf or wait or deliver? No, any patient presenting with irrespective of the gestational age, more than 20 weeks of gestation, go ahead and start magnesium sulfate in the emergency itself. That is a very, very important step which we have to do after stabilizing your ABC. Start your magnesium sulfate 4 grams infusion, then call the logicians and then control the blood pressure using Levitil. That's so. Irrespective of the gestational age, we have to do that. Any other questions?
Magnesium is the drug of choice both for prevention as well as for treatment of hypertension, as well as seizures in pregnancy.
So when we
if anybody is resistant or there is a recurrence in seizures, then comes the role of benzodiazepines. Otherwise, first line of drug would be magnesium.
Magnesium, not any other medication. We have to go ahead and give magnesium. Neuroimaging required guidelines for eclampsia. As I already mentioned, there is one condition that can be associated is most of the time if you do a neuroimaging, we'll see only the cerebral edema, not more than that. That another thing is the chances of having a intracranial hemorrhage is very high in this kind of patients. So that when the patient is not regaining consciousness after the seizure, after a post-ictal period of some half an hour to 1 hour, we can go ahead and get the neuroimaging of the patient. Third thing is the looking for press syndrome. If the patient is having a press syndrome, patients complaining of blurring of vision, all those things, it can be part and parcel of the posterior lobe encephalopathy syndrome that can be looked for. In that case, we have to go ahead and do a neuroimaging. Otherwise, there is no routine investigation of CT should be done in this kind of patient. Any other questions?
Yeah, one in the chat box.
For press, role of steroids. So usually the press, we won't give steroids. As I already mentioned, steroids are given for HELLP syndrome, not for the press. Press, if you ventilate the patient, take care of the cerebral edema, maintain the ICP, control the ICP, that is more than enough. There is no indication for steroids in case of press syndrome.
One important point to remember in the management of eclampsia is while giving magnesium sulfate infusion or giving as a bolus followed by an infusion, therapeutic level, it should be maintained between 4 and 7, which is above the normal usual normal limits. Usually it will be around 2.5, but here the therapeutic level that has to be maintained to prevent seizures or for management of eclampsia is 4 to 7. So that is the reason we always keep monitoring for any toxicity of magnesium and always check for all the 3: urine output, patellar reflexes, and respiratory rate.
Thank you, Ranjith. As specifically pointed out, whenever you start the patient on magnesium sulfate, your monitoring is very, very important. It may be this is the first line of drug, but it is not free of side effects. Always look for the patellar reflex. That is very, very important. At least you can just check for the patellar reflex before every 2 hours and document in the case sheet. That is very, very important when you are managing a patient with magnesium sulfate.
Yeah, before we close, Let me announce the next week topic. That's the Big Red. That's Management of Chaotic Disasters by Dr. Venkat Kotamraju, UK. So please do tune in at the same time.
Thank you, Dr. Naveen, Dr. Ranjith, and Dr. Srinath for giving me such a wonderful opportunity to share my thoughts regarding eclampsia. It's very nice presenting to you people. Thanks a lot. I'll also thank the Yashoda Hospital admin to write such a good thing. Let it continue. Thank you. Thanks a lot.
Thank you, Dr.